அவங்க அந்த இதை விரும்ப மாட்டாங்க. ம்.
Sir, we are just waiting for our guest of honor, Dr. Aram Sindil, sir.
No issues.
So waiting for him to join. If he joins, we can start the meeting, sir.
இன்னும் அவசரம் இல்லை சார்.
2 minutes, sir. We'll start it. Sir, Sendil, sir, have you joined, sir? Sendil, sir? Aram Sendil, sir?
வச்சு 94431 24412.
டாக்டர் ஜனனி, குட் ஈவினிங். ஜாயின் பண்ணிட்டேன்.
Good evening, sir.
செந்தில், வெல்கம்.
வணக்கம், நல்லா இருக்கீங்களா?
நல்லா இருக்கேன் செந்தில்.
Sendil, sir. Sendil, sir. Good evening. We are
குட் ஈவினிங், குட் ஈவினிங். அன்பு
waiting for
நாராயணன்
you.
அவர்களுக்கும் ராஜேஷ் அவர்களுக்கும்
சிவநாராயணன் அவர்களுக்கும் அவர் எங்க இருந்தாருக்கான ஆளா?
சிவன் சிவன் எங்கள் சிவன்.
Yes, yes, yes.
Manik's also is
Good
joined.
evening, good evening.
Dr. Janani, good evening.
Manikavasalam, sir, இருக்காரா? Sir,
Good evening,
join
sir.
பண்ணிருக்காரா Manikavasalam? So I think the people keep joining, so I think we can start the meeting. First of all, on behalf of IAP TTT, I welcome you all for Autism Awareness Day, CME. We have two eminent psychiatrists and excellent faculties here. They are going to enlighten us with their experience and especially this topic, autism, is always remains a gray area for all the pediatricians. In spite of our experience, in spite of everything, autism management is extremely difficult. It is a multidisciplinary approach. We have so much of we need the help of psychiatrists in many ways. So that's why we have brought two leading psychiatrists from Tirunelveli to our forum. So may I humbly request IAPTTT President Dr. P.T. Rajesh to address.
Good evening, all members and all specialists here. Autism is one of the emerging disease in children nowadays. So as a student, I had seen only one child, that too in PGI. So it was so rare. If somebody says that autism or ADHD, it was very, very rare. So we were reading only in books and we were not seeing cases. Now almost every third or fourth case is an autism child. And the pediatrician have a very important role in making a diagnosis of autism, because we are only seeing firsthand these children whenever they come for vaccine. And there's one problem in recent days is that most of the children go to vaccination in the government setup. So they don't see doctors there. So many children are missed out nowadays. So, and I always notice that whenever a child comes for vaccine at the age of 1 year or the 9th month, the way they produce sound, like say crying, for example, a matured, well-developed, well-communicating child will cry like amma, and the other children, all autistic children, will howl like, oh, it appears a meaningless sound. So with that alarms us most of the time. And we are handicapped with no therapy from our side as a pediatrician. So we see them only 1 or 2 minutes and we start seeing other patients. And we tell them, you go there, go here. And so there is no collective approach to this. And we are here to hear from Dr. Ramanujam and Janani about autism, so that we'll all be guided what to do. And so I thank our secretary in arranging all these things, putting all the efforts in making this happen. And I thank Dr. Aram Sendil, our EB members from our district, all those who have joined in the busy time. Thank you, and over to Secretary Narayan Sami. Unmute, Narayan Sami, unmute.
Thank you so much, sir. As you mentioned, it's a peak practice hours for most of the pediatricians, but still so many people have joined. But my special thanks to Dr. Aram Sendil, sir. ஒரு மிகச்சிறந்த ஒரு பேட்மிண்டன் வீரர், அது போக ஒரு அன்பானவர், பண்பானவர், ஒரு ரொம்ப நல்ல ஒரு மனிதர். ஒரு ஹீஸ் chairperson for AHA Tamil Nadu. It's an honor to welcome Dr. Aram Sendil, sir, and may I request Dr. Sendil, sir, to address, sir, please.
Aram sir, unmute.
அன்பு திருநெல்வேலி, தென்காசி, தூத்துக்குடி மாவட்ட கிளையின் பொறுப்பாளர்கள் ராஜேஷ், நாராயணசாமி மற்றும் பொருளாளர் அவர்களுக்கும் மற்ற செயற்குழு உறுப்பினர்களுக்கும் இந்த தொடர் மருத்துவ கல்வியில் நம்மை ஆட்படுத்த வந்திருக்கும் மருத்துவர் ராமானுஜம் மற்றும் குழுமி இருக்கும் அனைத்து குழந்தை நலம் அறிகிறேன். Autism Day awareness. It is really we are learning and unlearning and learning actually in autism. So we are seeing so many patients and we have got so much of clinical material. We should actually go for extensive research, and definitely we must find the multifactorial causes that contribute to autism, and we should be pioneers in this regard. This is what I've been telling all these years, because this type of patients are on the rise and it is an epidemic all these days. And we are not in a position to properly guide them. So we must be clear about what is happening in these children. And definitely, என்னை பொறுத்த வரைக்கும், நம்ம பார்த்த வரைக்குமே குழந்தைகளுக்கு ஒரு வித குழப்பமான மனப்பான்மை பெற்றவர்களுக்கும் இருக்கு, குழந்தைகளுக்கும் இருக்கு. பெற்றவர்களுக்கு இருக்கிறதுனால குழந்தை மேல அதை திணிக்கிறாங்க. முதல்ல எடுத்த உடனே தாய்மொழியில பேசாம அத ஆங்கிலம் தான் பேசணும் அப்படிங்கிற ஒரு ஆங்கில மோகம் நம்ம கிட்ட இருக்கு. அந்த ஆங்கில மோகத்தினால என்ன பண்றோம், in the formative years, when the neurological connections are happening and the neurological synapses are going, we are changing the course which have been genetically imprinted for so many years. So this sort of approach by the parents due to the environmental circumstances, and because Tamil Nadu and South India has been, because of its education due to English, we have come up, definitely the economic boom, and we have come up. But I would like to say that like breastfeeding awareness, like ORS awareness, we have to take this awareness to the pediatricians in a war foot. Like find out what is the core reason, why this is happening, how to prevent it, how to go about it even before 1 year or before the stimulation process. So we should all take it as a, because so many patients we are seeing. Definitely something has to be done, and I hope our psychiatrists and our developmental pediatricians will throw light on this. This is what I find as a clinician, what I am seeing in practice. This is my view. It need not be correct, but I feel definitely there is confusion in the brain that is happening because of the parents. Parents have changed. So this is what my small feedback, and thanks for the opportunity. And I request to, I'm really grateful for all the office bearers for giving me this opportunity. Thank you so much. Thanks for the opportunity.
நன்றி செந்தில் ஐயா, தங்களுடைய வருகைக்கும் வாழ்த்துக்களுக்கும். Really, thank you so much, sir, for your presence and your inputs. And it's time to, and I welcome Dr. Manikavasavan sir, the Joint Secretary Operation, and our State EB member, Dr. Shivanarayan sir. Welcome you both, sir. May humbly, and it's time to welcome our speakers for today's session. Both of them don't need any introduction, but still it's we take the privilege to introduce them. May I request the senior IAPN from TTT branch, Dr. Suresh sir, to welcome our Professor Dr. Ramanujam sir. Sir has been sacrificing his time in spite of his busy OP schedule. Welcome you, sir. Over to you.
Am I audible?
Yes, sir. Yes,
Very much
sir.
audible, sir.
So, good evening, one and all. Already in the running short of time. So, it's my pleasure and honor to introduce Dr. Ramanujam. So, he need no introduction because I know him from since my college days. He is my immediate junior in TMCH. So, அவர் வந்து அன்னையில இருந்தே அவர் எப்பவுமே ஒரு மல்டி டேலண்டட் பர்சன் தான். ஸோ சின்ஸ் த காலேஜ் டேஸ், ஸோ ஹி இஸ் இன்ட்ரெஸ்டட் இன் சோ மெனி ஆர்ட்ஸ் அண்ட் எவ்ரி சயின்ஸ் எவ்ரிவேர். ஹி இஸ் அ நோட்டிசபிள் பர்சன். ஸோ ஃபார் த ஃபார்மல் introduction, I think he studied his MBBS in Tirunelveli Medical College. Then he did his MD in Madras Medical College. Then after that, he worked in so many medical colleges as assistant professor, then associate professor. Now he is working as a professor of psychiatry in Tirunelveli Medical College. So he had published so many publications in the national and international journals, as well as he's a good orator. He had given so many lectures on the field of psychiatry. So he is a expertise in the field of psychiatry. He is a very good orator also. Then as well as he is a very much interested in a writer. He is writing not only in psychiatry. So he is an all-rounder. He write about the music, he write about the exercise, he write about the money, so many areas. He is very much interested. He is a very known person in the media side. He has written so many articles in the paper of Hindu, so many famous weekly, Ananda Vegadan, then Uyir Mai, so many magazines. He has written so many articles. He is a famous book on Manasukul Gym. Manasukul or Gym. It's a very famous book, very popular book. Even I have read that book. It's one of the best book I ever wrote regarding the self-improvement. So with this so much introduction, I over to Ramanujam for waiting for his vibrant lecture on the field of autism. Thank you, sir. Thank you.
Along with
Thank you,
Suresh, Ramanujam, and myself, we are runners of marathon. We have ran at least 3-4 together. So, welcome, sir.
So
Thank
he's
you
all
so much. Thank you so much, Dr. Suresh sir. And before we hear a lecture from Professor Ramanujam, we'll have one more introduction. We also have our another speaker for today's session, another talented young psychiatrist from Tirunelveli. She's a psychiatrist from Krishna's Child Guidance Clinic, Dr. Janani Madam. May I humbly request, and it's also I take the opportunity to introduce the pillar of our academic programs. Ever since January, we have started some academic program. The pillar, the backbone of the program, Dr. Madhav Sundari Madam. May I request Dr. Madhav Sundari Madam to introduce our another speaker, Dr. Janani.
Good evening, sir. Good evening, sir. Sir, am I audible, sir?
Yes, ma'am. For audible.
Yes, sir. Sir, ma'am in Salavanda, sir. I'm your junior. Good evening, sir. Good evening. Sir, good evening, everyone. Thank you, IAP TTT branch, for giving me this opportunity. It is my privilege and pleasure to welcome you all to this session. It is a great honor to introduce and welcome our esteemed speaker, Dr. Janani S. Prasanna, ma'am. Good evening, ma'am. Janani ma'am has completed her MBBS from PSG Institute of Medical Sciences and Research, Coimbatore, and her MD in Psychiatry from Amrita Institute of Medical Sciences, Kochi. She has further specialized in child and adolescent mental health with a postgraduate certification from Pathways Foundation, Coimbatore. Her journey reflects a deep passion and commitment towards child mental health. During her internship, she volunteered in government-run orphanages, organizing camps and counseling children. During the COVID-19 pandemic, she contributed to mental health services through Mehak Foundation, supporting online consultations and helpline services. Dr. Janani has also conducted several interactive workshops for parents and students, creating awareness and promoting early intervention in child mental health. She has previously served as member of the District Collector's Complaints Committee under the Sexual Harassment of Women at Workplace Act 2013. Academically, ma'am has also published the Journal of Pediatric Critical Care, contributing to the validation of Malayalam version of the Parental Stressor Scale in pediatric intensive care settings. Janani ma'am started working in child and adolescent mental health since 2021, shifted practice completely to Krishna's Child Guidance Center in 2024. Her clinical approach integrates evidence-based therapies such as cognitive behavioral therapy, parent management training, and positive behavioral support. Now, ma'am is also doing an advanced certification in cognitive behavioral therapy from the Beck Institute, Philadelphia. Ma'am, we are truly honored to have you here. Thank you, ma'am. Thank you.
Thank you so much. Thank you.
Thank you, ma'am.
Thank you, ma'am. And I think it's time to start the meeting. And finally, we have a vote of thanks from IAP TTT Treasurer Dr. Vivek, and then we can officially start the meeting. Vivek. Vivek.
Good evening, sir. Am I audible?
Yes, sir. Yes.
Audible.
Yes. So, respected speakers, Professor Dr. Ramanujam sir and Dr. Janani ma'am, so and my esteemed colleagues and active participants of IAP TTT. My heartfelt thanks to our IAP branch for organizing this CME on Autism Awareness Day, reminding us that every life has a value. So, I thank all the participants for your active presence and engagement, and let us start the event without taking much time. Thank you all.
Thank you, Vivek. Now, I cordially welcome Dr. Ramanujam sir to take over this session, sir. Sir, if possible, can you please share your screen?
Yeah. So first of all, I thank the organizers of PKTT, Dr. Narayanasamy and Suresh Rajesh sir, for giving me this opportunity. I am sharing my. Can you see the slides?
Yes, sir.
Yes, I'm able to see.
Yes, sir.
So as we are running short of time, I will just start immediately. So the topic is about the neuropsychology. So the pediatrician, as rightly pointed out by Rajesh sir, the autism, there is and also by Dr. Aram Sendil sir, there is a gray area. So there is a watershed area between pediatrician and the psychiatrist, the neurologist. So we need to have an integrated approach, and this topic will be about filling this gap. So pediatricians see what, so they see the cases, they see the symptom, and this topic will be mostly about why and where. So as I said, the neuropsychology. So for example, pediatricians see the absence of eye contact as a symptom, and here I will explain why it occurs, and likely I am not going detail to the etiology, which is beyond the scope, or also the management, which I think Dr. Janani will enlighten us. So my topic, so autism is, as we all know, so the Leo Kanner was proposed this. So originally, it was a triad of social dysfunction, communication, and repetitive behavior, and it has evolved a lot. Now, in both in diagnosis, etiology, neurobiology, and treatment. So prevalence and diagnosis. So what is new? So as Rajesh sir said, once it was a rare disease. Now, as he said, 1 in every 3. So the mild spectrum, I will explain that later. So at least 1 in 30 children is having, that is 3% of the children have a milder spectrum disorder. And regarding the diagnostic criteria, for autism spectrum disorder, so this is the DSM-5, the Diagnostic and Statistical Manual for Psychiatrists, the American Psychology Association manual. So previously there was the triad. One is the social dysfunction, another is the language dysfunction, and the third is the restrictive repetitive patterns. Now it has become a two. The social and communication and language has been integrated as social communication. So of that, we need to have 3. One is the deficit in the social emotional reciprocity, that is laughing, having a good conversation. And the next is the non-verbal communication. So this is given more important. So eye contact, body language, and pointing. And the third one is the difficulty in having relationship. So 3 of these 3 are required. And next mode is the domain, is the repetitive behavior, where we have stereotype repetitive behaviors, insistence on rigidity, we say highly restricted and fixed interest, a strong attachment to unusual objects. And one more important thing is the sensory reactivity. They will be either hyper reactive or hypo reactive to sensory input, and unusual interest in sensory aspects. For example, a particular sound, they may be irritable, hyposensitive, or hypersensitive. So sometimes they may not be sensitive to pain. Sometimes they will be exclusively sensitive to sounds like washing machine or the humming of this, all these things. So as we said, there are so many additional what we say specifiers like severity. So it is a spectrum. Autism is not a single disease. Nowadays, the concept is the spectrum concept. I will explain the next slide. So another important thing we have to learn is intellectual disability, mental retardation, which is sometimes comorbid with autism, but nearly 50% of autism spectrum, they have normal intelligence, and sometimes they have very good intelligence. We have the high functional autism. Again, language impairment. So not all children have language impairment. Some have only non-verbal and social communication problem. So again, there can be associated with other known medical and genetic, especially Fragile X syndrome is a very common cause of autism, and Rett syndrome is the molecular mechanism is known, and it is included in the autism. So now, as I said, the previous paradigm was we have so many conditions like autism, Asperger, childhood disintegration syndrome. So Asperger was autism with without language impact. So an odd eccentric behavior. They will have even they will, most of them have high intelligence. They will be like nerds, socially awkward, but they have good intelligence. Nowadays, everything has been shifted into autism spectrum disorder. So there is only one syndrome, varying severity. So with language impairment, without language. So Asperger will be nowadays autism spectrum disorder without language impairment. And as I said, that triad, social dysfunction, language and communication, repetitive behavior, has been made into two domains. One is social communication and restrictive behavior. So coming to the clinical thing, so these are all the social communication and joint attention. These are all the almost most early predictors. One is the lack of response to name by 12 months and absent pointing. That is called proto-declarative pointing. I will explain later. And poor eye contact, lack of shared enjoyment. The child does not share a smile or laugh while playing with a toy. These are all the social communication skill deficits. And coming to the behavioral rigidity, atypical toy play or the sensory hyporeactivity and visual fixation. Now, I am going to explain some of these symptoms and the neuropsychological models explaining this symptom. So, you have to understand that so the clinical window for early identification precedes even the normal language delays. So the language, the autism, the core insight that we have to learn is even before the language, that is called the pre-linguistic period. There are social and behavioral problems can occur, which can be diagnosed early. As Sir Rajesh sir rightly said, about 9th month during the vaccination. So the pre-linguistic behavior markers, as I said, the social communication and joint attention. So they group into three domains. One is behavioral, another is behavioral rigidity and language milestones. So we have the symptoms. As I said, these are all the symptoms. Now going to the circuit, there are some theories which are called, one is the model is called the theory of mind model. And another is the social brain dysfunction, and another is the executive dysfunction model. Another is called the weak central coherence model, and another is the enhanced perceptual function. All these 5 models of neuropsychological models, they are not mutually exclusive, but they explain the different deficits of autism in a different way. So theory of mind. So what is first coming? This is a very, very important model, which is called a theory of mind. So it is the ability to read others' mind, what the others feel and what the others think. So there are 2 components, what the others think and what the other feel. And we all know there are brain neurons called the mirror neurons, which are very important in this theory of. So as we say in Tamil, unkannil neer vadindal ennenjil udiram kottudal. So the ability to empathize with others, that is the one important function. So this is the development of the theory of mind. So theory of mind is nothing but the ability to understand other person. So that is the very, very important model explaining the social dysfunction. The children with autism, they are not having the ability to understand the other, they don't share with others. So these are all some of the developmental or the evolution of autism. The first thing is called the joint attention, which I am going to explain. So first is what is called the joint attention. So this is nothing but the child, the caregiver or the mother and the object. So these 3 form a triad and they interact with each other. So the child has to interact with the caregiver and an object. For example, the child has to show, for example, if she sees a toy, the child will show the toy to the mother. And the mother, and it should ensure that the mother sees. So that is a triad. So there are this joint attention is a very, very important function. And first it starts like receptive joint attention. So it starts by 6 to 9 months. See, it follows the mother's gaze. When the mother is looking at something, the child also looks. So this is called the receptive joint attention. So it is the first step of social relationship. So the child and the mother or a primary caregiver, they join together. So the next thing is what is called as a proto-declarative attention. So the child shows, it is pointing to that, say, cow or cat. And another thing is proto-imperative. So this is pointing to request. I want this. So this non-verbal communication, it starts even before the verbal communication. So it starts by 10 to 12 months. So that's why at the age of 9 to 12 months, this non-verbal communication is very, very important. And the next stage of joint attention is coordinated gaze shifting. So it looks at the object and shows to the mother, and again looks at the mother and ensures that the mother sees that object. So it is kind of a more mature social relation. So it shows it to the mother and it verifies whether the mother has. So it all or forms the theory. So this is what we see the joint attention. So this on the left we have the triadic interaction between the child, the mother, and the object. Whereas in autism, the child will not look at the mother or it will not show the object to the caregiver. So this is one important thing. So next thing, part of the theory of, so we are talking about theory of, this is a famous experiment, or sorry, a test called Sally-Annie test. So it is a test to, this question is asked to children of about 5 years. So it is for example, this gives a scenario where there are two, the blue is called Sally and the girl wearing the pink is called Annie. So when the Sally leaves, the Annie puts the marble in her basket. So when Sally comes, she will look into her basket. But children with autism, they don't understand that Sally will look into her basket. They will say that they will look into the box where the marble is. So this is a test for theory of mind. So this is a very interesting test, and many of the children with autism, they failed. So coming to the theory of mind, we all know that there is a area in the medial prefrontal cortex. So, and again the temporoparietal junction. These two areas, they form the social brain network. So the child, when it interacts with the other, these are all the two areas that are responsible. So the next model is so we talked about the theory of mind. Another is the social motivation model. So there is an area we all know in the brain, the limbic pathway, that is called the reward pathway. It is a way of relating to others. So whenever someone appreciates, it's a positive feedback. So the rewarding, and criticisms are taken as a negative feedback. So our social behavior is mediated by the rewards. We do something for, when the mother appreciates, the child does that. When the mother reprimands, it doesn't do that, or it stops. So this pathway is impaired in autism. So as a result, the child is not at all interested in social interaction. So eye contact is absent. So that is a behavioral red flag. Absence of gaze contact. And shared enjoy, it does not enjoy because of it doesn't feel, in the social interaction is not at all rewarding. So the child doesn't share play. So that is a very, very important. So that is the one important aspect. So again, we say the social motivation hypothesis. This means the parent often reports that the child seems to be in their own world. In fact, the name autism derived from this concept. So self-absorbed behavior. So the mesolimbic pathway, the brain does not process human voice or face as rewarding. So that is the decreased social attention and lack of social specialization. So that is the difficulty in forming a relationship. Another, so because of this, there is the language dysfunction also occurs. For example, delayed babbling. So language requires attention. So language requires attention into the patient, caregiver's sound and others, and it has to be a rest. That's why language is very much. Also, there is a synaptic abnormality in the areas, Broca's area and the Wernicke's area. The neuronal pruning and all abnormalities caused, especially at 12 months delayed babbling. And again, one other important non-verbal is the mimicking. So as the child is not having attention or social cognition is impaired, it does not attempt to mimic like waving a bye-bye or clapping hands or mirroring a simple facial expression. So the child does not look at the caregiver and mimics. So lack of imitation is one more red flag. So eye contact, absence of babbling, and lack of imitation. All, as I said, even before the language starts, this pre-linguistic behavior or social abnormalities can be seen. So again, one important clinical red flag we say is the regression. So loss of acquired skill is a very, very important finding for autism. So rather than development, so if the child has a regression, the language becomes regress. That is one classical feature of autism. So the third model denotes, that is what is called the, it is based on the frontal lobe. So the dorsolateral prefrontal cortex is like a switch which can, it is responsible for the flexibility. For example, if you are going in a traffic, we just turn right or left. So we either do something or stop. It is called go, no go task. So this is done by, this flexibility is done by our prefrontal cortex. So for example, if we ask the patient to tap once when we are tapping twice and tap twice when we have tapping once, this is done by our prefrontal cortex. So patients with frontal lobe dysfunction, they fail in this task. So this ability to switch on and off is lost in autism. That's why they are with rigidity. The insistence on sameness is because of the problem in the executive function. So that's why the dorsolateral prefrontal cortex acts like a switchboard. It is like a switch which connects to the behavior. So as we have the cortico basal ganglionic circuits are impaired, so this causes rigidity. And it is not a stubbornness, but it is a compensatory mechanism. So it, as the brain struggles to switch, we also see such a type of, it is called perseveration. So belonging to the same thing again and again. So this is also seen in late stages like dementia. So the third is, the fourth and fifth models involve this sensory perception. So one important thing in autism is some of them, they have savant skill, that is extraordinary skills in especially music or maths. It is because the sensory areas, normally there will be, they are filtered or they are controlled by the higher cortex. So, and this higher cortical control and the integration is done by the parietal lobe and the frontal lobe. So this is not done. So what happens is that there is an extremely sensitivity to the all the ability to attend all this stimuli. For example, now I am talking, there are so many input into my brain. There is a fan running, so there is some other things happening in the background, but my brain ignores them. And so that I am concentrating on this lecture. But in a patient with autism, what happens is this filter, this is called a sensory filter mechanism. And this filter becomes dysfunctional. So all inputs gets bombarded. So the brain does not know what to react, and there is no meaningful measure is made taken. For example, so this again, the fifth model is called the enhanced perceptual function. So that's why it is a hyper reactivity to sensory input. For example, a hum of the refrigerator or a texture of the clothing. So all this, the brain does not know how to ignore. So when someone is talking to us, we see their faces. There are movements in their mouth. There is sound. We see their visual. We have a visual input from their faces. All this, we even touch them. All this gets integrated and made as an one stimuli. like watching a movie. So, but children with autism, this integration is not done. So, this made into, they are looking at not as a whole. For example, if children with autism, if normal children, if they see a train, they see see it as a train. But a patient with autism, the children with autism, they see only they are sensitive to a particular point. For example, only they will play with the wheel. So this is called a exclusively hyperreactivity. So again, this hyperreactivity to only a focus, that's why some of them, they have unusual skills. Some may have calendar memory and some may have superior mathematical or musical skills because of detailed focus, the inability to filter unwanted things. And it is also responsible for exclusively sensitive. That's why they are overwhelmed by the background. So as I said, there is a visual cortex or auditory cortex. The frontal lobe inhibits. So this is called a filter. So the irrelevant sensory signals are filtered off. So that's then the brain requires only what is needed. This is not done in autism. So as a result, see, for example, a car, the child sees only intense focus on parts of the objects or sensory output rather than the intent. So we say the child is looking too much into the tree, so it loses the sight of the forest. That's why it is the one important thing. So again, we see this is what is called as a neurotype. Normal brain, there is a global processing. All the inputs are processed and then made into. So whereas an autistic children, that is the bottom to up process. So all the details bombard the brain. So this coherence is lost. So that is the result. So as I said, these are all the bottom up data flooding the system. So that is why it explains the hyperreactivity to textures, lights, and background noises. So again, hyporeactive and hyperreactivity or neurodivergent sensory process. So we have the 5 models. So one is the social motivation, the mesolimbic system, the theory of mind, where the mirror neurons in the medial frontal cortex and also the superior temporal sulcus are involved, and the frontal executive function, which is responsible for the rigidity and the perceptual processing done, that is the parietal lobe integration is lost. So the visual or sorry, all the sensory stimuli are integrated. So all these 5 models, so the diminished eye contact, the social motivation hypothesis explains that, and the difficulty with the social rules and all these are explained by the theory of mind. The insistence of sameness or rigidity is explained by the executive dysfunction, that is the dorsolateral prefrontal cortex, DLPFC, we say that. And again, the final 2 explain the savant skills and also the details, the sensory hyperreactivity skills. So autism, there is one important thing, enhanced local activity. So some areas, the local areas are hyper reactive and there is an aberrant abnormal connections. We don't know the etiology, and the long commissural or the long range integration is absent. So one lobe to another lobe, so central to peripheral, parietal to occipital, all this long range connectivity is absent. So there is like so many like a country where there is no central integration. All there is so many autonomous regions. They have their own rules like that. In autism, this is the most important problem is the long range network dysfunction. So finally, we have the 18 months checklist. The first one is if the child is not responding by the name and if it is not pointing to show, and the third one is the eye contact. If it is not eye contact, it's used. So this is at every 12, usually 18th month, or even before that, we can do that at least 12th month. And imitation, that's the child mimic simple action, and pretend play, that's the child feed a doll or talk to a toy. These are all some of the 5 big red flags which is mentioned. And as Rajesh sir said, it is very important to screen at the age of 9th or 10th month. So in our government, I mean Indian government, the RBSK scheme, they screen for 30 diseases, and one of them is autism. So they have a similar checklist, and the village health nurse and the school visit, they have to check for autism, and they have to refer if these are present, and we use the M chart or the modified checklist for autism for toddlers. And if there are two big red or red flag signs are present, they have to refer to. Now in our government setup, they refer to the DEIC or the District Early Intervention Center. So the behavioral checklist and DSM criteria tell us what the child is doing, and the neuropsychological models tell us why they are doing. So for example, in understanding the insistence is a working memory mechanism, or the sensory hyperactivity is due to autonomous cortical quiet. So this our clinical approach from merely managing behaviors to underlying the neurobiological or neuropsychological models may help the pediatrician. And as rightly pointed out in the beginning, we need a lot of integral research between all the departments. So that is the main aim of this meeting and this autism awareness day. So thank you for giving me this opportunity.
Thank you so much, Professor Ramanujam, sir. It was such a wonderful session to listen, and thank you so much for being an eye-opener session. Literally, we should say that. So thanks for very big thanks to you once again.
Thank you,
Sir.
thank you.
Thank you so much, sir. And without wasting much time, I humbly call upon the second speaker, Dr. Kennedy, madam, to give a lecture. Please.
I hope my presentation is visible.
Yes, ma'am, it's possible.
Yes, visible.
It's visible, madam, visible.
Thank you so much for inviting me to this lovely day. It's a day we all have to remind ourselves on this growing knowledge on autism. And thank you so much, Dr. Ramanujam, sir, for enlightening us on the neuropsychological model, such an explicit talk on the neurological underpinnings of this a very challenging subject. I hope you can share the presentation with me sometime. I will beg to take it from you. And I'll start without any further delay. So my topic is emerging technological advances and management of autism spectrum disorder. So management starts with assessment, and assessment starts in identifying these children, and identification starts with these lovely screening instruments which have been created. And one of the commonly used is the modified checklist for autism in toddlers, MCHAT. And MCHAT is available in our national languages. It's trademarked with high sensitivity in picking up neurodivergent children starting from 18 months of age to 30 months. And the other screening tool is the Childhood Autism Spectrum Disorders Test, CAST. Once we identify these children, it's also important that we rule out the medical disorders which are possibly there with these children, such as the Fragile X or the Down syndrome or the Rett syndrome that sir had mentioned earlier, neurofibromatosis. It's important that we try to discriminate children with autism features from children with pure autism spectrum disorder. And finally, currently, we make a diagnosis with a detailed history, which includes developmental history and understanding the divergent behaviors that sir had mentioned, and also our observations when they present to us in our clinical OPD. Now, once we make a diagnosis, it's important that we quantify the severity of these children, and this forms a baseline for us before we start any kind of therapeutic intervention. Most commonly used tool is Childhood Autism Rating Scale. The CARS-2-ST is a revised version. There's also a separate version for higher functioning children who are more adaptive. And ISA, the Indian Scale for Assessment of Autism, gives severity and is commonly used for disability certification. Coming to the management of autism, there are two different ways. One is pharmacological and non-pharmacological, but pharmacological takes a back step here. as we have understood that our neuropsychological understanding has just started in the last few decades. The pharmacological aid seems to be more reserved for children who have difficulty with impulse control, who have difficulty with emotional regulation. The certain groups of drugs which are used are antipsychotics for irritability and aggression. Antidepressants can be used for repetitive behaviors, also for some self-injurious behaviors. Alpha agonists like clonidine have been used for hyperactivity and also for self-injurious behaviors. Stimulants like methylphenidate and atomoxetine are reserved carefully for those children who have comorbid ADHD, specifically diagnosed. Melatonin is a sleep hormone which is given for those children who have rhythm disturbances. Our main topic for today is the non-pharmacological intervention, which is the cornerstone for autism spectrum disorder management as of today. That is our therapeutic interventions. So what are the goals for the therapy? Our main goal is helping the children communicate better, function in their everyday life easily, regulate their emotions with ease, and also build a vocation which starts with building academic skills. Now, I would be actually explaining 5 important therapeutic interventions which will help us understand the technological advances. Starting with applied behavior analysis, which is substantially researched, strong evidence-based. And here we are understanding why a certain behavior happens. Now, understanding the behaviors behind every children is very important for any child, not just a child with special needs. And with a child in autism, it seems to be very crucial to differentiate repetitive behaviors from tantrums, from any kind of temperamental disturbances like biological rhythm disturbances. So in applied behavior analysis, we try to understand what precedes the behavior, which is the antecedent, and what follows the behavior, which is the consequence. Now, reinforcement is one of the methods where we change the consequence, that is, positively reinforce the consequence so that the behavior happens again. Well, prompting is a principle which is used to change antecedent to help desirable behaviors repeat again. This concept seems to be the basis for a lot of behavioral interventions in autism. It helps us understand a lot of deficits across all domains. The next is alternative augmentative communication. This, as the word says, alternative communication, seems to be a very crucial one for children who cannot communicate, and not just non-verbal autistics, but also any child who has communication difficulties. And AAC has successfully busted the myth. Non-speaking means non-thinking. A child who can't speak immediately, back in the day, 50 years before, we think that they had nothing going in the brain. And that's been completely replaced by AAC, which is done through gestures, through pictures, to devices. I have displayed a couple of pictures here. The first being Peck's book, which is called as Picture Exchange Communication System. Now, this is a book form. There are also board forms for the PECs, where these pictures are attached to a Velcro. And this picture explains how a child is starting with a training with the PECs. So basically, there are 6 phases in PECs. And the first phase is when a child gives a picture during the training so that they get the object back, where a reciprocal interaction is basically taught to the child. The reciprocity being very difficult for a child with autism, this is the first phase for it. And from there, from the phase 1 to phase 6, slowly the children are built into sentence making, where they can communicate and they can share their needs. This is a picture of the Avaz app, which was created by an IIT alumni back in 2010. And his idea was to take it very portable, because books or Velcros are extremely heavy. There are even certain keychains for these AAC, but still these pictures are quite difficult for children to handle, because some of them would need close to 100 pictures in their hand. So that becomes very portable through Avaz app. Flow time therapy was introduced by Dr. Stanley Greenspan, who was a child psychiatrist back in 1990s. So this therapy is a naturalistic intervention. The whole idea was to create a bond with the child by the parent or the caregiver going down at the level of the child. Now here we try to engage the child through the shared interests, and this is also called as a DIR model, which basically stands for developmental individual difference research based. where we are trying to individualize a therapy for a child. This is social stories, another behavioral intervention which is given for children to overcome the difficulties in theory of mind. So this social stories is also called a social narrative, where we help them prepare for situations. It can be new places or meeting new people, or even making changes in their everyday routine. As Dr. Ramanujam sir had told, it's very difficult for them to make any change in life. They're extremely rigid and inflexible, and social narrative helps them to flexibilize themselves, get themselves prepared. It can take for some children a week, it can take some children a day, but this would help them prepare mentally, expect the behaviors in advance. Now, this social stories is something that can be tailored according to a child's understanding. Not all children cognitively work at the same level. So here is a picture of individually how small social stories could help a child. Well, my next slide is talking about different other social stories. Left above, you can see it's a social story on emotional control, while next it's about the child going to a store with the mother, what the child has to anticipate while going to a store. Now, there's another version in which this is given for a child who needs to understand social rules. Conundrum is it is a social conundrum for them. It is quite difficult for them to understand what they have to expect when they go to playground and see other children. So again, some kids might like it in this order of presentation. And then the last one is an essay where a child is writing an essay in a pictorial way, and this pictorial depiction can actually in turn help them to comprehend the situation. So if you can see, every social story is done according to their cognitive level of understanding. Sensory integration therapy. So this comes as a part of occupational therapy, extremely crucial to these children. Like sir had told, how sensory overload can disturb their attention. So this helps them to process their sensory disturbances better through structured sensory experiences and completely play-based. I have presented a picture of our CGC's sensory room. The last couple of therapeutic interventions which I would like to touch upon. So if you see, the traditional speech therapy is actually expanded a little bit. They don't merely stick to communication skills and articulation. They're slowly expanding it to social skills training, which work better for older children when their comprehension is built a little better. TEACH, which is treatment and education of autistic related communication handicapped children. It's a structured teaching program which includes visual aids like PECs, which includes even structured activities. It is individualized and curated according to each and every child's features or difficulties that they go through. Cognitive behavior therapy, again, another substantially researched, strongly evidence-based psychological intervention. CBT for those children who are verbal can be done without any visual aids, but non-verbal also, they have done a lot of research with the visual aids. CBT helps, which is cognitive behavioral therapy, helps in overcoming impulsive behaviors, helping them manage anxiety, helping them with problem solving, and with visual aids, they can overcome everyday challenges better. So the other aspects which have to be taken care for the child are the academic skills, where inclusive education, where they do have a curriculum according to their challenges, and occupational therapy, which focuses on motor and sensory control. Motor coordination seems to also help in improving their attention and learning. Now, moving to the technological extensions of this traditional interventions that we just spoke about. How is technology changing our autism management? So technology has helped with diagnosing children easily earlier, making therapy more accessible, individualizing the therapy, enhancing independence for these children, personalizing their learning, and providing consistent insights into their progress. These are the list of technological advancements that I would be just mentioning about, starting with screening, which is AI-powered, to telehealth therapy platforms, VR, AR platforms, smart devices, education apps, and sensory-friendly text to robots. AI-powered screening, the current one, which is novel and very innovative, is the social interaction recognition AI developed by Electronics and Telecommunication Research Institute in South Korea. So they are still working on it. I don't think it is quite easily accessible. But the idea is basically their system helps in analyzing short videos of toddlers responding to cues. They help in detecting early warning signs such as limited eye contact. And also these AI diagnostic tools, they also try to pick up speech patterns, facial expressions, and also repetitive behaviors. Telehealth therapy is something that is happening even today. It's quite common now, especially post-COVID. We have live virtual therapy sessions for speech therapy, even occupational therapy, psychological interventions such as ABA and CBT, remote parent coaching for parent management training, digital behavior tracking. There are apps that logs the moods, meltdowns, and triggers in real time. Therapy portals. Now, these therapy portals, they form almost like a self-help group and a community for the parents, therapists, and educators to collaborate. The virtual reality-based therapy via platform, the one being studied currently is Florio, which has received FDA recognition. They use immersive environments to teach conversational skills, emotional recognition, and help them with everyday activities such as shopping, crossing roads, classroom behavior. Imagine a child has, instead of imagining it internally, they get to see a picture of what they're going to expect instead of the social stories in the form of pictures. Here we have a video-based illusion, a video-based rehearsal of what they have to expect in their everyday activities. So that's how these immersive environments work. So these actually deliver even applied behavior analysis based principles. So they have engaging game-like formats to reduce anxiety and increase motivation. The augmented reality-based therapy. So the picture I have shown is a head-mounted AR application called as Magic Bubbles. So the child is actually mounted it on the forehead, and when they are visualizing it, they are able to have these in numbers, which actually has a description of the object. Now, this usually helps in reducing their sensory overload, helps them processing information much better. So this helps in autistic children to improve their interactive skills, attention skills, so that also reduces their anxiety in a way. Here I have two pictures. One where a child with an augmented reality head-mounted appliance is actually doing a social skill program, and another one where the father is actually training the child into social skill training. We are in an age of smart devices, and smart devices are from glasses to watches to shoes to everything, but there are two commonly used ones now, at least they are coming up into the market. Now, these smart devices are powerful real-time insights into emotional and physiological states. The picture that I've shown is a Google Glass, which uses AI-driven recognition of facial expression to help them detect the emotions. They help in picking up social cues. They have interactive games to practice facial expressions. Now, also these, these smart devices such as the smart watch, which I've shown below, they help in predicting the emotional meltdowns by monitoring the heart rate and the movement patterns. This sort of also helps the caregivers to pick up the child before they get aggressive or they have an emotional outburst. It improves the safety as well. On the whole, wearables promote greater independence, reduces anxiety in public environments, and they help in better social communication. There are education apps for pretty much every class now. And so it's not surprising that we have for the neurodiverse population. The one that I have shown is actually from an app called Lingo Kids, who also have such educational module for ADHD and dyslexia. Sensory-friendly technology. This is quite popular now, noise cancelling headphones. I think all of us, even the neurotypical, use them these days. But the idea behind children having this is, again, to reduce their sensory overload, to help them pay attention and respond in a better way. The last one, which is the most novel and innovative one, are the social robots. These robotic companions, they are promising effective tools for teaching communication, emotional awareness, and motor skills. The one above first is the Cute Robot, which is being made in the University of Birmingham. This is actually made for home program to support parents in teaching language and social skills. The picture below is NAVO, which was designed and studied in Paris, France. This is used to improve emotional recognition, encourage joint attention, and support motor coordination. I'm finishing my talk with a word on our day, the World Autism Awareness Day today that we are observing. And this year's theme is Autism and Humanity, Every Life as a Value. So through all these advances, helping them in management through the technological advances, we're trying to give equal rights to these individuals, respect them in a shared human future, appreciate their uniqueness, provide them quality opportunities equal to the neurotypicals, and finally, help them to be one among the society, include them everywhere we go. Thank you so much.
Once again, very big thankful to Dr. Janani Madam. Actually, we informed Madam about the program only 2 to 3 days before. In spite of the short notice, Ma'am has come out with an excellent presentation. It's really a new learning. We have learned so many new things which we are literally unaware of. Thank you so much, Madam. And hopefully in another 1 or 2 years, we would like to have all these facilities in our district too. Thank you so much, Madam.
Thank you so much.
Finally, a big thanks to Professor Ramanujam sir, Dr. Janani Madam, President VT Rajesh sir, Treasurer Vivek, all the office bearers, and all the participants who participated in the wonderful CAB. Thank you so much. We are just signing off. Thank you.
Thank you.
Thank you so much, sir.